I'm Dr. David Johnson, Professor of Medicine and Chief of Gastroenterology at Eastern Virginia Medical School in Norfolk, Virginia. Well, earlier this year, I launched a discussion as it relates to the GI microbiome, and I started and led with the esophageal microbiome. I'll provide a link to that. If you haven't seen that, please take a time if you have a chance to look at that. And today I want to talk about the oral microbiome because this is an area that entirely, I think, we're missing the boat as care providers, unless you're a dentist. Now, the oral microbiome is a complex and diverse ecology, and it's made up of bacteria and fungi and viruses and archaea, and certainly bacterial species number in excess of 700 species just in the oral microbiome. And we talked about the oral microbiome and recognize their microenvironments. So you have the lingual surface, you have the buccal surface, the gingival surface, the hard and soft palate, the hard surfaces above and below the gingiva as it relates to the dental surface areas. And all these seem to have very unique microenvironments. And with that, there seems to be a misunderstanding that these alterations in the oropharynx may have systemic effects. And there's clearly data to actually say that's entirely the new norm, that we need to understand this better. Let's talk about it. Particularly, I'm going to focus on GI disease, but recognize the systemic effects of upregulation here have been linked to systemic diseases such as cardiovascular disease, diabetes, neurodegenerative diseases like Alzheimer's, a number of things as it relates to chronic kidney disease, and cancers, and certainly inflammatory diseases, rheumatoid arthritis, and then the host of inflammatory diseases as it relates to GI, and in particular inflammatory diseases in the liver. And we'll talk about fatty liver and cirrhotic disease in a second. But why would this relate to a gastroenterologist or a care provider talking about the oral health? Because we think about oral health, and if you go to the dentist, they tell you you need to brush and floss. It prevents dental caries or mitigates risk for dental caries and gingivitis and all those things that relates to periodontal disease. Recognize that periodontal disease and it really can be more on the periodontitis is certainly something that relates to bone resorption, so we're talking about more accelerated, and there are certain stages of that, but let's focus on just the association of microbiome changes and different associations with GI. Let's talk with cancer to start, and cancer is one that really, we go from cavities to cancer because some of the disease organisms and things like Fusobacter nucleatum and Actinomyces adenolyticus, those are diseases that are bacteria that have been related to dental caries, but now there's emerging and very strong evidence that relates to GI cancers, particularly colon cancer. Why is that? Well, the gingival inflammation promotes blood flow. That blood flow mitigates towards a barrier integrity decrement, and so you may have integrity and translocation, as well as systemic upregulation of cytokines and chemokines, and certainly we see this in looking at systemic evaluations. But the translocation then can deliver either the bacteria, fungi, or virus, whatever, to another location, or parts of that, for example, lipopolysaccharides, which are part of the cell wall and a gram-negative, and deliver that to the tissue to mitigate processing. And certainly things that we know in the cancer pathway have been demonstrated are upregulation of adhesion cell type process, activation of toll-like receptors, signaling reactive oxygen species upregulation, ultimately the generation of mutation-inducing DNA changes. So cancer, as it relates to oropharyngeal disease state, that certainly makes sense, in particular colon cancer. But there's also the same data that would also imply even for colon adenomas. The odds ratios in one study that I saw was equated to equivalence of smoking, so we know that has an association with increased adenomas. Certainly the same as it relates to gastric cancers like gastric cancer itself, pancreatic cancer, so the association with odds ratio changes in dysbiosis in the oropharynx relate to those disease states. Interesting one also that caught my eye was it relates to H. pylori. Not only the prevalence of H. pylori in the oral cavity, concordant with the prevalence of H. pylori in the gastric area, but also as it relates to treatment response. And there was a randomized controlled trial looking at mitigation with a triple therapy for a 10-day course, not 14, which is the standard now, but looking at the effect of scaling and route planning and oral hygiene instructions for that period of time, and there was a 12% increment in eradication of H. pylori. So again, I'm not sure that we talk about that when we talk to our H. pylori patients, but certainly is something to take note of. It relates to other disease states. Certainly we can see the association for liver diseases being a very strong association. And what's talked about is the inflammation as it relates to brain, gut, liver axis. And certainly this is something that I think is something we need to pay attention to. Longitudinal studies have shown an association in increased odds ratios. A very interesting study that I saw that was done in rabbits. They actually injected a gingivalis species that was injected in the rabbits and in a model for fatty liver disease, and it accelerated the inflammation and the levels of GGT, which are a surrogate marker for the inflammatory injury, and showed a progression more towards fibrosis and related progression. A radio-labeled study, also in again in animals, injection of the same oral pharyngeal cavity-provoking type species, showed up in brain, liver, kidney, and the GI tract for sure. So as we start to see about the oropharyngeal translocation risk, we certainly see it as a real deal as it relates to the ability to mitigate at a local level, as well as translocation to another more distant level. And it may be the product or the byproducts of these bacteria in those given areas that make a difference. Certainly the area of cirrhosis, we see an incredibly strong prevalence of periodontal disease in cirrhotic patients. Dr. Josh Bajaj and his group at Virginia Commonwealth actually published this a couple of years ago. They looked at intervention in cirrhotics that had no encephalopathy, but they were actually had minimal hepatic encephalopathy, which we don't test for very well, but they actually showed marked improvement in cognitive scales and also in quality of life scales by referral to a dentist to address oral hygiene and periodontal type care. As it relates to inflammatory diseases, certainly the colon and small intestine, as we see for Crohn's disease, and colon as we see in inflammatory bowel disease in our specialty. I highlighted two studies that profiled from Digestive Disease Week 2024 that looked at the association with oral health and dysbiosis and inflammatory bowel disease. And one in particular caught my eye as it relates from Dr. Keshavarian's group in Chicago, where they talked about a bidirectional effect of periodontal disease and intestinal inflammation. So again, it may be bidirectional, but certainly a high association. So what do we do with this? I call this low-hanging fruit. We as gastroenterologists or primary care, whatever your provision of your specialty or common practice, we can do better. And recommendations to improve dental care certainly should begin with see your dentist twice a year. They're the experts. We're not. If they're not capable for access or whatever the insurance related, you may be the only one to impress on how important the oral dental care is, and dental exams. But brushing twice a day, lingual brushing, dental flossing, use of antiseptics, mouthwash, toothpaste, those things are all very simple and very composite to good common sense. They promote dental health. But now we're talking about more systemic disease health and prevention of systemic disease progression. Well, maybe we should take a lead from our dental colleagues who have emphasized dental health and oral health for a long time, and maybe we can be better dental advocates, if not dental assistants in some regard, not to subrogate to the experts, but nonetheless to recognize how important it is to our patients. Take a minute to prioritize, synthesize, and make this another area of expanded care. We treat so many things just with take this medicine, take this injection, this pill, whatever. We can bridge much more to a personalized care if we start to look at other things as it relates to oral health. Dr. David Johnson, please prioritize this next time you see your patient. And thanks again for listening.